Hello, everybody. Thank you for joining. We've had a bit of a last-minute change of plan. So for those of you who don't know me, my name is Dr. Lizzie Tuckey. I'm the MD of Scan UK. I'm delighted to be hosting this webinar this evening. We run monthly webinars with Scan to educate practitioners, GPs, allied healthcare professionals about musculoskeletal or soft tissue injuries and how and when to order imaging. We also have previously had one talk actually on the head, neck and brain. And the slight change of plan this evening is that we have reached into our network and are delighted that Dr. Tabish Saifee could join us tonight. And he'll be talking, he's a head and neck and neurology expert, and we'll be talking about common conditions that are managed in the community and how and when to book secondary care referrals and what imaging to order. I hope that's right, but he can introduce himself a little bit more. So just on that, I will take you through a little bit about scan.com before we hand over. So basically, if you are a physiotherapist, osteopath, chiropractor, or GP, you can book imaging on our portal. We are like the booking.com of scan.com. It's super easy to refer one of your patients. You can self-sign up on our portal, or you can actually just directly refer from our website. And if you're seeing a patient live in clinic, you can book them into an online slot, or you can send them a link to book in at a later time. And we're completely transparent about the price of the scan, anything ranging from around £300 to around £600 for an MRI, depending on which facility you're going to. But you can click this QR code here to sign up for an account. There's no need to have an account. You can refer off our website. All of your images and reports will be available in the portal that will be created from the referral. And in addition to that, your patient will receive a scan slated report, which is our AI tool that interprets things in non-medical jargon. I'm going to hand over to our speaker this evening, who's very kindly stepped in. He's a consultant neurologist and is an expert in brain health and brain scans and anything to do with your neurological system. So thank you very much for stepping in this evening, Tabish, and we're really looking forward to hearing you speak.
Thanks for the invitation to speak. So I'm Tabish Saifee. I'm a neurologist, and it's a real pleasure to speak to you all. I'm going to talk to you about a pet interest, which is about movement disorders and gait disorders. It's Tuesday evening. It's pretty late, so I thought I'd pepper this talk with a few videos that I've cobbled together. It'd be good to keep this interactive. I appreciate that's a little bit limited because I can't hear anything, but do feel free to put things on the chat and I'll try and monitor that, and Lizzie will hopefully bring to my attention any questions. But yeah, feel free to interrupt if you have anything to add, any questions, any experiences yourself. So I have a busy NHS practice in general neurology and movement disorders particularly. I also see patients privately and have a private practice in central London and also West London. A bit out of the blue, but we were going to talk about movement problems. And one very common condition causing movement problems is something called Parkinsonism, the commonest cause of which is Parkinson's disease. I thought maybe we'd start with this question. Can somebody put into the chat what they think is not a key feature of Parkinsonism? So I want you to have a think about what you understand as Parkinsonism, and tell me which of these is not a typical feature of Parkinsonism. Is it bradykinesia, which means a slowness of movement? Is it a postural tremor, which tends to be a tremor when patients have their limb or other body part supported against gravity? Is it rigidity? That's a sort of type of increase in tone in the limbs typically, but perhaps even axially or in the neck. Or is it something called postural instability? So we've got lots of different answers here, which are great. Good few of you saying B, some postural instability, and that's all brilliant. So the answer here is actually postural tremor. So Parkinsonism is a triad of bradykinesia, which is a slowness of movement, rigidity, which is an increase in tone, and postural instability, although that tends to be something that happens a bit later on in the condition, not so early. Postural tremor, and I'll give you an example of postural tremor, is sort of this, when your hands are shaking, they're held in a fixed position up against gravity, and they're shaking, and that's called a postural tremor. Whilst you might see that in Parkinson's disease, it's not specific for it. So it's quite a non-specific symptom that can happen in many other scenarios. The classic type of tremor that we see in Parkinson's is rest tremor. So let's move on. I want to show you a patient of ours with Parkinson's disease. This is the commonest cause of Parkinsonism, but there are other causes. So sometimes medications or drugs can cause Parkinsonism. We can see it in other neurodegenerative diseases of the brain, of which Parkinson's disease is one, but there are others. We can see it with vascular disease in the brain. So that's strokes and small vessel disease affecting the brain can present with Parkinsonism. Imaging is very important in this scenario because it helps to tease apart those patients with vascular disease in the brain. And there can be clues in terms of differentiating the other types. So whilst imaging won't give you the answer, it's a very helpful clue if you're trying to look for different causes of Parkinsonism. So let's have a look at this chart. So Parkinsonian gait. So this is where the walking is interrupted or affected by Parkinson's disease. And there are very typical things one might see. So somebody might see a stooped posture, the arms might be a little bit flexed, and there may be a tremor in the hand. So tremor in Parkinson's is most typically a rest tremor. So that's the hand sort of resting down on one's lap or on the arm rest, and the hand starts shaking. Usually it's a sort of what's called a pill rolling tremor. So the thumb and forefinger shaking, but again, not with posture, but at rest with a hand down on the lap. You might also see a tremor when somebody's walking, and that might be a tremor in the hand. In fact, that's really typical and a very good clue. So sometimes when I see patients and I call them in from my waiting room, I'll see them walking in. What's shown here in the cartoon is highly caricatured, and it's rather severe features of Parkinsonism. And it's less likely you're going to be seeing a client or patient with this extent of signs or symptoms without already having a diagnosis. But of course, you may be seeing them if you're physiotherapists, for example. You may well be asked to see patients with Parkinson's disease who may look like this or may have motor features as severe as this. But if they're newly diagnosed or at the verge of being diagnosed, they may have just very subtle signs. And as I said, one very nice little clue is the patient walking in with a little tremor in just one hand as they walk into the room. 8, 9 times out of 10, that will turn out to be Parkinson's disease. Their base, meaning the separation of their feet when they walk, is normal. It's not widened, but they have slightly short and shuffling steps. Hypomimia means the sort of facial expression or spontaneous facial expressions are a bit reduced, and patients may develop gait freezing. And allied health input here, particularly physiotherapy, neurophysiotherapy, is really important and such a key part of treating this condition. So this is a gait disorder. So this is a patient who came to see me. He's a young man, and he's a boxer. He started to develop some problems in his legs. He described them as weakness, and he felt a little bit imbalanced, and found that walking was increasingly difficult. In fact, he was now occasionally using a wheelchair, which he had access to. I think it belonged to a relative in the house. It wasn't his. I examined him and I tested for tone and power, which were normal. The reflexes were preserved, but they were absent at the ankles, and that's a little clue that there may be a peripheral nerve disorder. I tested the Babinski reflexes, so the plantar responses, and these were extensor on the left. So that's a sign of an upper motor neuron syndrome. So we've got a mixture here of a lower motor neuron syndrome with the absent reflex and an upper motor neuron syndrome with the extensor plantar. He also had a very wide, unsteady gait, and his Romberg's test was positive. So Romberg's is a really useful test. That's where somebody has a bit of unsteadiness and you're trying to decipher the cause. And I'm going to come back to what Romberg's test is exactly and how it works and what it tells you. I tested joint position sense in the feet and vibration in the legs, and these were reduced. This is a chap who, when he was walking, had just a little bit of a tremor in his right hand, and that was the rest tremor I described. And this is a patient with early onset Parkinson's disease. This is a different form of disorder, and you can see from the static picture here, this gentleman's got something called the retrocollis, which is where his neck is tilted right back. He presented with initially very mild symptoms in the neck, with a pulling back in his neck, with some neck pain. Does anyone know what type of abnormal movement we would call this? So this wasn't a fixed position. It would be a little bit mobile, and it would be dependent on the position he was in. It would depend on what he was doing. But how do we coin this type of abnormal movement? Any ideas? Yeah, dystonia, somebody said, so very good. So dystonia is an abnormal positioning of a body part, and it usually involves a twisting component. It's usually mobile, so it's not usually a fixed abnormal movement. You can see this chap has retrocollis, which is a type of cervical dystonia. Cervical dystonia can come on in adulthood as an isolated phenomenon without any other problems. It can sometimes be related to other problems that may be neurodegenerative changes, there may be metabolic disorders, there may be drug-induced causes, or even genetic causes. And of course, when you're trying to differentiate these, you look at the story, you look at the age of onset, you look at where the dystonia is it in the neck, is it more generalized within the body, etc. And this helps tailor trying to find out what the specific causes are. The next case was that of a 41-year-old woman who described some painful cramps in her hand when she was writing, and also when she was playing the piano, but her hand was otherwise normal, and I examined her hand and it looked entirely normal. But when she was writing, she had significant problems trying to write, and her hand would take on an abnormal, slightly twisting position, and the pen would be really forced down into the page when she wrote. And her hand would usually ache and cramp after writing for a period of time, usually after one or two lines. Does anyone know, what would you describe this condition as? Dyskinesia, that's a good thought. Dyskinesia is quite a broad, generic term for abnormal movements. This isn't specifically dyskinesia. This is a type of dystonia. It's a type of focal dystonia in the hand that's sometimes called writer's cramp. Writer's cramp is quite a common type of focal dystonia in adulthood. There are a few focal types of dystonia we see in adulthood. So generalized dystonia, where the whole body's affected, is more typical of something we see in childhood, whilst the adult forms of dystonia tend to affect bits of our body. So cervical, like we've seen with the other chap, focal hand dystonia, i.e. writer's cramp, like we're seeing with this woman here, or another form is with facial dystonia, particularly eye closure and dystonia around the mouth, which we might see in patients in their 50s or 60s. That could be isolated and sometimes related to certain medications. Imaging, of course, again, is always important to rule out or to help you in terms of investigating for other causes, which may be structural causes within the brain. So thinking about dystonia, there are a few specific features of dystonia. And if you think you've seen dystonia, it's quite helpful to look for little clues, little clinical clues that will help you. One of these is not a clue for dystonia particularly. Does anyone know what the answer to that is? So which of these is not a typical clue for dystonia? Is it something called a gest antagonist, or a sensory trick is the other term for A? Is it a sensory trick? Is it mirroring? Or the patient may have a coexisting tremor, brisk reflexes, or present on action. So which of these is not a typical feature of this abnormal movement called dystonia? Any thoughts? Do put it in the chat. E, yeah, good thought. So present on action. Anyone else? Okay, Well, the answer is actually D. So brisk reflexes are usually a sign of something called the upper motor neuron syndrome. So that's damage to the pyramidal tracts in the brain or in the spinal cord. So that's the one thing that you wouldn't typically see with dystonia. In fact, if you do see it, then that's just another part of the nervous system that's damaged. And that is a clue to something called a combined dystonia, where you don't just have dystonia, you've got dystonia with an upper motor neuron syndrome. But dystonia alone comes with these other 4 features. So gest antagonist, or a sensory trick, is a very unusual specific thing where a bit of sensory input seems to change or improve or modulate the dystonia. An example is dystonia in the neck, cervical dystonia. One of the commonest forms of dystonia usually presents with a bit of turning of the neck, often pain in the neck. And what you'll find is patients, particularly quite early on, have a little trick where they might just touch their chin. I'm not talking about pulling their head back forcefully, but just a very slight light touch of the face or the chin or the back of the head. And that sensory input up into the brain seems to modulate the motor output, and it can transiently normalize the abnormal position. It's a really good thing to look for. Mirroring, you might see in something like writer's cramp, where you've got focal dystonia in the hand, you're asking somebody to do something like write, and you might see some abnormal dystonic positioning in the other hand at rest. So whilst that writer's cramp is starting to take on, you might see some of that, some mirroring onto the other side. Nice little clue. May have a coexisting tremor. So tremor is a rhythmic oscillation of a body part. Again, a bit like this. With cervical dystonia or any form of dystonia, along with the twisting, abnormal positioning of the body part, you might also see a bit of shaking. So I'm going to have to mimic all of these movements now, but you might see a bit of shaking of the head, for example. With dystonia, for example, cervical dystonia, we'd want to investigate the patient initially by taking a history, examining them, and we would rule some rarer things out with blood tests and an MRI scan, typically of the brain and the cervical spine. It's not typical or very common to find secondary pathologies causing that, but it's important to rule them out. Finally, present on action. So typically you might see people with dystonia have quite mobile body parts. So that neck is not fixed in one position, but rather you'll see it changes as they're doing things. Often when people are walking, certain types of dystonia, particularly dystonia in the neck, might be brought out. So have a look at them doing different things, and you might see the dystonia changing. Okay, I'll talk a little bit about tremor, which is this sort of rhythmic oscillatory movement. Tremor can be at rest, which we've talked about, which is often Parkinsonism, or it can be on action. Action could be a kinetic tremor, where you're moving a body part from, let's say, finger to nose. It could be postural, when you've got the hands just against gravity in a fixed position, or something called isometric tremor, where somebody's pushing against a fixed force. So that could be the legs pushing against the floor when somebody's standing up. That's a form of isometric tremor. Or when somebody's in the gym, for example, pushing up against a weight. In fact, it can be in extreme quite a normal phenomenon for some people. You may have experienced that yourself if you've done any form of resistance training and tried to go for a really heavy weight and just notice that sort of final isometric tremor with a very heavy weight. But of course, tremor can be pathological. This is a patient of mine with a postural tremor. He's had this for about 30 years and it's gradually got worse, and it's in both hands and it looks a bit like this. And when he moves his finger from the target to nose, the tremor is also there, and that's the kinetic component. It transiently improves with alcohol, and there are a couple of other family members who have this, and that's a condition called essential tremor. Essential tremor is quite common. It probably affects 1 to 3% of the population to varying degrees, and it needs to be investigated, particularly with certain types of blood tests. If you think there are other features, then imaging can be useful. If it's pure essential tremor alone, then imaging may not be necessary, but sometimes it's necessary when you see other signs or other features. And it can be treated, and there are medicinal treatments. There are what are called functional neurosurgical treatment options. This is a chap who is who came along and saw us rather urgently because he had developed this sort of flailing movements. I'm going to try and mimic it because I've not presented you with any video. So his arm just started flailing around like this. So he was just sitting at rest, and on one side of the body, his leg would also sort of come up and just flail around, and so would his arm. And this is something called hemichorea or hemibalism. That's another type of abnormal movement. And this came on rather abruptly. So we did a scan of his head. And in fact, what we saw here are some very subtle changes here on one side of the brain, deep in the basal ganglia. And that's consistent with either one thinks about a stroke, because that can cause these sort of abnormal movements on one side, or hyperglycemia. So in fact, we tested his blood sugar and it was sky high. And this was an unusual presentation of type 2 diabetes. So a patient who never knew he had diabetes but presented in this way, and the imaging really was critical. So this is the differential diagnosis of hemichorea. So polycythemia, which means a rise in the hemoglobin level in your blood, hyperglycemia, which I've given you an example of, or an acute stroke. I'm going to mention one other type of movement, and this is a sort of generic type of movement disorder. This was a case of a 50-year-old gentleman who had a road traffic accident and a whiplash injury. And it was a minor whiplash injury. He had a little bit of pain around the neck. But then he started to develop rather abruptly later that day a very severe tremor. So the tremor was about this amplitude. It remained for months, and he came to see us, and it was extremely disabling, as you can imagine, both hands shaking very violently. Now, we looked at him, and the very abrupt onset of the abnormal movement was in itself a clue. We then tested a few other things, and I'm going to sort of be examiner and patient here at the same time, but one of his hands was shaking very vigorously. And what I asked him to do with the other hand was to mimic movements that I was making. So I was making tapping movements with my fingers. And so he was having to mimic that tapping. And as soon as he started mimicking it, the tremulous hand took on the same frequency as the tapping. So just to show you again, he had this very severe tremor. He had to then copy what I was doing. And as he did that, the tremulous hand started taking on the same movement. And that's called entrainment. There was another sign he demonstrated, and this was that when the tremulous hand was outstretched, rather severe tremor, I asked him to make little movements. I would put my finger out, and I would make a little movement of my finger, and he would have to follow that movement. As soon as I made a movement and he had to follow that movement, there was a little pause in the tremor each time. And this is called a ballistic pause. So you'd have to make a little ballistic movement, and that would cause a pause in the tremor. Does anyone know what this abnormal movement disorder is called? So these little pauses, this sort of attention-dependent movement disorder. So when he was unable to pay full attention to the tremor, i.e. when his attention was diverted to the other hand, doing a complex task, or not even a complex task, but a simple task like tapping, it would change the nature or the characteristics of that tremor. Does anyone know what that is called? So that's something called a functional neurological disorder, or specifically in this case, a functional tremor. Functional neurological disorders are very common. In fact, they're thought to make up a significant part, perhaps 10%, 20% of all patients seen in neurology clinics, and they can take on different forms: functional tremor, functional seizures, functional weakness. They're different. They're very characteristic because they're a group of conditions that are very real. They're clear and disabling to the patients, and they're not made up. But they're different to organic conditions where we might see structural damage to the nervous system. In these set of conditions, we don't tend to see structural damage to the nervous system. Of course, we will want to rule a few other things out, and that might be using blood tests and imaging of the brain and the spinal cord. But once we've excluded other possibilities, we use very positive signs like the ones I've showed you to make a diagnosis of a functional neurological disorder. These used to be coined as psychogenic disorders, or even many decades, over a century ago, what Freud described as hysteria. we now don't use those terms, and we understand that these conditions are very common and they don't have to coexist with psychopathology like depression or stress or anxiety. Whilst those conditions are a bit more common in this context, they're not necessary for the diagnosis. And to dismiss these patients as simply hysterical or it's all in your brain or it's all in the mind is really to sort of underserve these patients who are very clearly disabled by their conditions and need help. It's not useful to say to these patients, well, nothing's really wrong with you. It's important to make a very positive diagnosis and say, yeah, look, I know what this is. This is quite a common condition. This is a functional neurological disorder. And really the way to treat this is not through pharmacology. It's to rule some things out, like I've talked about. It's to rule the condition in, and then to use a very sort of holistic approach to treatment. And that holistic approach usually means taking a very therapy-based approach. So that might be physiotherapy. It might be things like speech and language therapy. It could be cognitive behavioral therapy. It very much depends on the constellation of symptoms and signs that the patient presents with, but usually a sort of very multidisciplinary approach to managing these patients is important. One caveat: this is a condition that has become sort of entered the common parlance, and many of you may now may be familiar with this or becoming familiar with this condition. What I would caveat against is making a diagnosis of this condition where the problem looks unusual and you're not sure what it is. And I'm starting to see that, and I don't think that's a good way to make this diagnosis. It's important to make the diagnosis in a positive way, meaning you recognize the syndrome, and if you don't recognize it, then referring to a neurologist to make that diagnosis. But then as an allied health therapist, perhaps as a physiotherapist or other, as I've described, you might have an important involvement in the long-term management of these conditions. Look, I'm going to pause there. I've got to say apologies for the videos. I've had a bit of issues with the audio, on the platform. Perhaps that's been the issue. I'm not sure. But I'm very happy to take any questions you might have if you want to put any into the chat. Unfortunately, I can't hear any of you. So how did the patient with the whiplash start with a functional neurological disorder after a trauma? So, well, that's a very interesting question. And often the trigger for a functional neurological disorder, the clues are that they often start fairly abruptly, and they're usually precipitated by something. So myself and a colleague wrote up a big series and published a big series of these patients. And the vast majority of patients had what we described as a precipitating event. And this precipitating event could have been anything like a fall, an injury, a minor whiplash injury, a drug reaction, all of which were felt to be fairly sort of contained, not likely to cause persisting damage to the nervous system, yet it somehow triggers what is described as a functional neurological disorder. So I sometimes ask patients to think about FND or functional neurological disorders as the brain going into a habit of developing an abnormal movement. Now, that is not by no means a perfect description of what's happening, and there's some issues with using that sort of analogy, but it can be an analogy that you use to try and understand what's happening. That this is not something that the patient is sort of very voluntarily putting on. Some people use the term involuntary rather than involuntary or voluntary. It's sort of in this sort of grey no man's land of involuntary, if you want to use that term. But it's certainly disabling, and taking patients' attention away from the movement disorder can be helpful. It's also helpful from a therapy point of view to try and help patients achieve a specific end goal in terms of a movement, rather than breaking that movement down. So from a therapy or physiotherapy point of view, instead of trying to ask the patient to sort of take one step and then the other, instead of breaking the gait task down into specific discrete components, that tends to worsen the problem. In fact, what you really want to do is distract away from the very overt control of the movement and allow the more automatic form of movement control to take over. And that's where patients do well, where they're not concentrating, not putting attention on delivering the movement, but they're allowing the more sort of automatic approaches to take over. So will the FND possibly correct itself, or is it lifetime management? No, I see lots of patients. Good things that help patients with FND are an early diagnosis, a very positive diagnosis, and early intervention. And those things are very helpful. Also, those patients without a lot of other comorbidities and without a long history of FND tend to do well. Those who don't do well tend to be the ones who've had, 5 years of this condition, patients who've been treated badly or diagnosed badly early on. So lots of patients who are sort of brushed under the carpet. Doctors or other people say, well, there's nothing wrong here, there's nothing to see, you don't have cancer, you don't have motor neuron disease, you don't have, this is not a this is not this is a very clear diagnosis that you need to make. You don't need to be telling them that you don't have cancer or you don't have motor neuron disease. Those things are not helpful to a patient. If you developed a tremor or you developed an abnormal movement, you'd want your doctor or your health professional to tell you what the problem is, not to tell you a sort of a list of things that it isn't. So make sure that they're given a very positive, clear early diagnosis and signpost them to helpful websites and information and support. For example, John Stone's neurosymptoms.org website is a very helpful website. If there's no other pharmacological management for FND, the only advice will be therapy. What are the risks of FND going undiagnosed? I think for a long time, there's been a lot of FND that has been undiagnosed and has been a big problem for that reason. I think increasingly neurologists have been, I think, at the forefront of this. Certainly other specialties and many allied health professionals have been very important in increasing the awareness. And I find that many people are now fairly au fait with this, but things were very different when I was initially in the field, 15 years ago, when we were publishing in this area. It was certainly an area that was far less well understood or accepted. If I missed any other questions, would presence of chorea be a medical emergency to rule out a stroke? If the chorea comes on abruptly and if it's down one side of the body, yes, then that's a pressing matter, and that is a patient who should go to an urgent care centre or A&E. If chorea is coming on gradually and it's not just down one side of the body, then that's not necessarily an emergency, so it doesn't need to be dealt with in a very urgent matter. But certainly any sort of abnormal movement that is coming on abruptly, number one, or any sort of abnormal movement that's affecting just one side of the body, then you very certainly need, as a general rule of thumb, urgent brain imaging in that sort of scenario. I didn't get to finish. I thought I'd just tell you the end. That there was a chat, the chat with the poor balance. I thought I'd just finish it off quickly. We did a scan of his cervical spine. You can see right at the back of the cervical spine, there's this white matter change. Sorry, there's this signal change, T2 signal change right at the back of the spinal cord, just over here where I'm pointing with my cursor. And this is damage to the back of the spinal cord that carries proprioception up towards the brain. In fact, that boxer who had the balance problem had that scan of his spine. And the reason for it were these. Anyone recognize what these are? These are called whippets, and they have nitrous oxide in them. I'm sure many of you are familiar with nitrous oxide now. These little canisters are called whippets, but I just pulled this up off the internet because this is actually what the canisters look like nowadays. They're these big, huge, massive canisters. Some of you may recognize these polluting the streets over the last few years, but these are tiny little canisters. The doses people use now are huge. And I think the dose in these blue large canisters is probably 70 times the dose in these small whippets. It's a recreational drug. It's very common amongst teenagers and people in their early 20s, particularly men. I've seen a very large number of people in London with nitrous oxide induced damage to the spinal cord and these are young, otherwise very well people using it as a recreational drug. It interferes with the metabolism of B12 and damages the spinal cord. And these patients need to be picked up early. And the clue is that they're sort of imbalanced. So any young man who's sort of developed a rather abrupt or over a few days or weeks balance disorder, think very strongly about this. I'd say about 50% of the young people I see with this condition, I ask them about nitrous oxide and they're always very cagey about it. You have to ask them 2 or 3 times and be very probing about their use of nitrous oxide. It's very common, don't miss it. Anyway, I'll close there. Thanks very much. Oh, sorry, there's another few questions to deal with. How much would they need to be using? So that's a really good question. There are probably genetic factors that determine how susceptible you are to this. Of course, if you're susceptible from other ways, for example, if you're susceptible to B12 deficiency, let's say you're vegan or your B12 intake is low, then you might be even more susceptible. So it can vary quite a lot, but that's a very good question. Usually I tend to see people using this over at least a number of months, going to nitrous oxide parties, once a week on a weekend for a few months is usually sufficient. What's the treatment? Treatment needs to be early. Stop nitrous oxide, don't use it again ever. And secondly, B12 injections. Oral B12 is useless. It will not replenish the B12 that's required. Is full recovery possible? Definitely possible, but it's got to be done early, and you've got to be rigorous about stopping nitrous oxide and replacing B12 with injections. Injections are 3 times a week for at least 2 weeks and potentially beyond. First step in primary care. Is that regarding nitrous oxide? Is that your question, Kavya? This is a tricky diagnosis for primary care and won't get picked up in primary care. Is this something a GP would be able, this is not something I've seen a GP diagnose. They'll pick up the abnormal gait. I guess that's relatively simple to do because the gait is something called a sensory ataxic gait, meaning you don't know where your feet are in space. That's proprioception. Usually when we're walking, we look straight ahead. We don't look down at our feet because we've got sensory information coming up from the feet up towards the brain. But when we have B12 deficiency or we use nitrous oxide to this extent, it damages those ascending sensory pathways towards our brain through the sensory nerves in the legs and through the back of the spinal cord, like we can see on this scan. So when you damage that, you don't know where your feet are in space, and you need to look down at your feet when you're walking. I mentioned Romberg's. Romberg's is a good test for this because what a patient does is they keep their feet together and they should be steady. And then you ask them to close their eyes and they become very wobbly. Because if you lose proprioception or joint position, you're really dependent on vision. So you need to look down at your feet. You need to look at the ground to know where your feet are in space. So Romberg's is basically turning that vision off and seeing that balance gets much worse. It's a really good test for that. Would MRI show any specific structural changes? Well, that's a really good question. And yes, to an extent, it's not absolutely specific for B12 or nitrous oxide alone. There are a few other differentials, and I've mentioned a few here. For example, copper deficiency, a bit rare. Some infections, HIV. I mean, this was back in the day where, viral loads were huge and it would develop into something called a vacuolar myelopathy. We wouldn't see that so commonly now. Usually, if we see this sort of picture, it's nearly always going to be inflammation like multiple sclerosis or some sort of vitamin deficiency like B12. Those are the biggest, commonest reasons we'll see something like this. So it's relatively specific for this. But really, as soon as you see a young man, 20-year-old young man, imbalance, this has to be the very top of your list of causes.
So much.
I'm going to say bye-bye. Thanks very much, Lizzie, and thanks, everyone.